we're going to talk about the new type of simulators that we are making. You can see the conventional simulator there and conventional laparoscopic surgeries. So how do you do conventional laparoscopic surgeries? You distend the abdomen with the gas. So what are the problems with doing that? Any idea what are the problems associated with distending with gas? Normally do you have a lot of gas in the abdomen? We don't. So when you put a lot of gas, it compresses the various organs. The vena cava, so blood supply to the heart is reduced, carbon dioxide gets absorbed. A lot of physiological changes which affect the anesthesia and the well-being of the patients. And also it's an artificial setting. It's not, it's quite dissimilar to the natural surroundings. And then the conventional way of training is using these boxes. And if we look at the pictures inside the box, it's nowhere near what it is normal. You don't see the normal structures, normal this thing. And again, I would say that use learning skills in the box is more difficult because the surroundings is all white and you don't really have the depth perception because you're seeing the images in the 2 dimensions and tasks are 3-dimensional. So you need to learn a lot of things which are more difficult. And again, what you see them doing is different. I mean, peg transfer, that and those other things, which we don't really use in the actual setting. So we are trying to make a simulator which sort of, at least approximately or initially simulates a natural way of doing things, so that more people convert from open surgery to do laparoscopic surgery. Right now, only 10% of the world they do laparoscopic surgery. 90% still do open surgery. And we have had a lot of training programs where people come and learn like this. Then they think it is actually difficult, so they don't, because it's not easy to learn these skills. So then they give up. But in reality, actually, if you look at it, after we started learning straight on the patients, and I never went back, I find the simulator more difficult. And is much more easier in the reality and patients because you have a lot of landmarks and it's easy to operate. So that's why we have developed a thing. This is just a first prototype. So I'll just show you what are the things which are possible here. So, and this is another instrument that we developed. What does it look like?
Cystoscope.
Yeah.
Cystoscope.
Is it like a normal cystoscope or anything different? It's a cystoscope, agreed.
It looks like a normal cystoscope.
Yeah, it looks like, but then is it different?
Short length.
Connected to a wire.
No, not the short length, this is the conventional length.
Everything. Only the
light source.
Camera, light source.
Yeah, so usually, normally, why are we doing, when you're doing a cystoscopy, all you need is the pictures in the monitor. But why are we, normal cystoscope has a bridge, a telescope, a camera, a light source, a monitor. Why are we doing that? Because there's a tradition. A lot of times we don't want to move away from what we're traditionally used to. But actually we don't need the telescope. Because if you look at telescope, the sheath will cost about 20,000-30,000, the bridge will cost about 10,000. And the telescope costs about 3 lakhs. And then you have a camera which fits onto the telescope, which will cost another 3, 4, 5 lakhs. Then you need a monitor, you need a light source. So this is a simple modification of that. We have just a camera that you pay instead of the telescope. And you get the pictures in the laptop. So you do away with the expensive stuff like the telescope, you do away with the monitor, you do away with the power supply and all those things. So this is like any other telescope except that it's a camera and the thing. And the way you hold the telescope is that you hold it like this. And generally you hold the penis like this, and in reality use the thumb and index finger to open the meatus. Then we lubricate nicely, and generally this is the smoothest part of the telescope. So if you poke like this, all these areas it can poke, can cause injury. And urethral tissue is very sensitive. Even minor injuries can lead to stricture. So generally you pass like this. Then go in and turn. So in the next, this thing is this is how a normal urethra will look like. And you should keep it at the center and then gently, slowly pass. I am not using hardly any force. You go there. Okay. And then you reach a place called Verumontanum. Have you heard of it?
Yes, sir.
So what is the significance of Veru? So when you go to the Veru, is it a good structure or a bad structure?
It's a landmark.
Okay, it's a landmark where the sphincter is. So if you're doing especially resection and no injury, if it will cause the damage to the sphincter, which means that urine will keep leaking. You make the patient really worse because of that. Okay, and then this is how a normal this thing. If you look from the Veru, normally you should be able to see the bladder. And so once you notice, you go there, you change the direction. Normally you go like this, and then you make the curve straight, so that because this is a rigid instrument. So you go here. Then this is how the bladder neck will look. Then you look at the bladder. And since this is a normal telescope, only difference here and normal cystoscope is the normal cystoscope is 30 degrees. So you can look down. This is till now it's only 0 degree. So you have to look up straight. So you look for the ureteric orifice. Okay. So we have simulated the ureteric orifice here. So this is one side. Then you follow what is called the interureteric ridge. Then you can go to the other side and look at the ureteric orifice. And we are recording in 360 degree camera because you need to first go straight, then turn up, then go inside, then again turn. All these movements, if you just keep looking at the monitor, you won't understand. So you need to have that is the reason importance of having the outside pictures and the monitor pictures. So a lot of times, in fact, once you're doing a URS, right up to the kidney. So you go into the bladder, all the urethral curves, then bladder, then the bladder curves and goes up and down everywhere. Then you go and pick up the stone. And the patient asks you just went and picked it up and you want 3,000 or 4,000 for this. Because they keep only looking at the monitor. You don't see anything. That's why it's important to have a simultaneous view of both structures. Okay, and then we also, I don't know whether they got the DJ stents.
Yes, sir.
Yeah, so then guide where is the? So you what need to practice. One of the important skills that you need to learn is putting a DJ stent. Because earlier when we were traveling, every month we used to find people coming with acute renal failure because of bilateral ureteric stones. All you need to do is a simple procedure. You can save their lives and morbidity and so much problems associated with the renal failure. You need to go to dialysis and a lot of problems there. They develop acute renal failure. And then also, we'll also later, if we have time, we'll show you how to do the urodynamic studies. That will help you to evaluate the lower urinary symptoms. So these three skills, you can treat almost half the urology patients you see in any conventional OPD. We have done a lot of studies to show that about 5 to 6% of patients you see in any OPD will have urology problem. So right now the shortage of urologists even in US and Canada. So here we can understand we have one urologist per 6 lakh population. So, but then every 1,000 in 1 lakh population, you'll have 6% having urology problem. So you need to, these are the three skills that if you need to learn: how to do a cystoscopy, how to do a DJ stenting, how to do urodynamic studies. You can treat more than half the urology patients you see. And this is the, and the other problem we said about conventional laparoscopy earlier was that you need gas. So when you have gas, you need to give general anesthesia. And the medicines which are necessary for general anesthesia compared to spinal is so much more expensive. Spinal will send hardly few hundred rupees, while it will be in thousands of rupees for general anesthesia. Then you have the logistic problems of getting all the anesthesia gases, both for surgery and for anesthesia. You also need an expert anesthesiologist to give anesthesia because of all the physiological changes which occur. Generally, the BP is huge. A lot of, you need a CO2 monitor, you need a lot of these things. But if you do gasless laparoscopy surgery, then you avoid all those problems. You have, you can do it under spinal anesthesia, which is cheap. There's no physiological changes, so you don't, many places we are done with nurse anesthetists. Or MBBS doctors can give anesthesia and then operate. So gasless has a lot of advantages. And now, this is the cystoscope, which is also very cheap. This costs less than 50,000 rupees. Instead of 10-12 lakhs we need for conventional cystoscopy. You can use the same thing for, actually even he was commenting, he wants to operate with that. So here what we are trying to do is we are simulating the normal intestines. So here you'll see, this is not very realistic now. We're going to, he's an artist who is going to make realistic looking things inside. So how do you find where the appendix is? Give me one clamp, any laparoscopy instrument. So this makes even single incision surgery is also possible. Normally it's, if you do single incision surgery with conventional, it's you need a special port which costs 15,000 rupees. Then we need special instruments of a delicate 75,000 rupees which breaks. Here you can use the ordinary things. And skin stretches, so you can move. And normally when you do conventional single incision, what you normally do the right hand, you now do the left hand, and vice versa. So here is not like that. So what you do is, with the way, later on will be even more layers. So you just push the intestines away and use gravity to move it away. Okay. And then you can see here we are given some gloves which look like the appendix. Okay, so you can catch appendix and then you can knot and tie and use. You can practice that later. Okay. And if you want, you can do it with single incisions, or you can, we have made some places for port. So you can use, one more instrument. Okay, so what you can do is, okay. So you can catch the thing, pull it up, yeah, lock it, and you can use the instrument in other places to tie. So you can practice all those things. And we also made a gallbladder model, which is not yet complete. We'll probably later on we'll do the thing. And then we can also make a hysterectomy, ovarian cyst, and all those things. So you can come and practice how to. This gives a realistic appearance of the thing, what you actually will do. And also here we have the field of vision is limited. So a lot of these things, each time, all these actions, you need to do it by remembering how it is. So you won't be able to trace the instrument right from the port to this thing. But then you need to learn how to come to the site which is necessary. So I'm not even looking there. I'm just going to the correct site because the body has a memory. And if you practice in a model like this, you'll develop that memory. You'll develop the angles, how to do the things. So if you practice how to do appendicectomy here, it's very easy to go back and do the appendicectomy in a real patient. Because if you have done 10 times here, it will be easy when you go to the real patient. But there, if you go and practicing in a box and immediately even 20 times you do, you will find it still difficult to do it in the real patient because everything is different. There you are comfortably standing here and doing everything. Now suddenly you'll have to go here, you'll have to push the assistant away and so on. Here it gives a more realistic thing. So this is a model which is almost realistic because this is the first prototype, it's not very good. But after some time he can assure that it will look very real. and then it's easy to learn surgical skills, especially the things. And once you practice, then it's easy to convert to this. Okay, now you can practice scopies, then appendectomies, and these are guys who are working in rural areas and they're used to gasless laparoscopy surgery. They'll demonstrate how to do it and then you can do it. Thank you.